Good morning, everyone, and welcome to another Community of Practice for Ontario Family Physicians. My name's Ali Damji, and I'll be your moderator for this morning's session. We have a really great session planned covering infectious disease updates, managing alcohol use, and practical tips for a restful summer. So quite a theme going on here. And I just will turn things over to Dr. Eric Wong. He's subbing in for Dr. Mihaly Kumanen today, and he's the Secretary-Treasurer of the OCFP. Over to you, Eric.
Great. Thank you, Dr. Damji. So good morning, everyone. Again, I'm Eric Wong, family physician from London and the Secretary-Treasurer of the OCFP. So on behalf of our president, Dr. Mihaly Kumanen, I want to welcome you all to today's session. I also want to thank our speakers for bringing us some amazing content today, and our OCFP staff and committee members who support this session. As a reminder, this session is certified for Maple Plus credits, and details about that will follow. We acknowledge that the lands on which we're hosting this meeting include the traditional territories of many nations. The OCFP and the FCM recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and the FCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. I'm calling in from London today, located on the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and Chilcotin nations.
So I just wanted to recognize today as part of our reflection that today is National Indigenous Peoples Day in Canada, which is an opportunity for us to celebrate the contributions of Indigenous people across Canadian society and to Canada. And so I'd encourage everyone today to think about how they might celebrate today. Perhaps when you're out in the land, thinking about where we're all placed right now in the traditional lands on which we're gathered, thinking about how we must be allies for Indigenous peoples, and thinking about some of the opportunities for us to be better allies and the opportunities to better advocate as well. So I know I'm certainly keeping that in mind today, and I hope you will as well. Next slide. Again, I just want to iterate to everyone that this is a Main Pro accredited session, and I want to thank the planning committee as well, who helps put the sessions together. Next slide. And so this will be the order of the presentations for today. So we'll start with Dr. Warshafsky going over infectious disease, then to Dr. Wyman, and then over to Dr. Chan. So I'll start first with asking Dr. Warshafsky to introduce himself and to declare any disclosures.
Yeah. Hi, morning, everybody. Daniel Warshafsky. I'm the Associate Chief Medical Officer of Health. I don't have any disclosures today, but I have like a small baby with me for a short time. She'll be going soon, but she's cute and stuff. So.
Well, welcome to both of you as panelists today. Over to you, Dr. Wyman.
Good morning, Jennifer Wyman. I receive a salary in my role as educator and clinical programs lead with Medify, and have received funds from the Ministry of Health for developing various educational programs and supports for speaking for the AFMC and OCFP. Thanks.
Thanks. Over to you, Dr. Chan.
Morning, everybody. I earn my income mostly from OHIP. I also am faculty at McMaster. I earn some income with speaking as well as some organizational stuff with OCFP. And then I also have a private coaching and education business that's through my MPC right now. So that's another way I earn income.
Great, thank you. Dr. Wong.
Hi again, Eric Wong from London. I do receive stipends from various organizations listed on the slide. None of these associations pose a conflict for today's session.
And for myself, I receive compensation from the OCFP for moderating these sessions. And apart from that, no other financial disclosures. Next slide. So as a reminder to our participants, please use the Q&A function on the bottom of your screen in order to ask questions. I see a few of you who have already started, which is wonderful. And remember that if you want to ask a question, please do take a look through the questions that are already posted, because someone may have already asked what you wanted to ask. And if they did, just give them an upvote. So then that way that will come to the top, and I'll ask the questions with the most upvotes. And again, a reminder that please use the chat box for networking purposes only. Use the Q&A function for questions, so that way it's all nice and organized and your question doesn't get missed. Next slide. So we'll move over to Dr. Warshafsky to kick things off.
Great. Thanks so much, Ali, and morning, everybody. So we can go to the next slide. I'll just start off with a quick reminder of where we're at right now with our COVID vaccination campaign. So it is still the spring campaign for another 10 days, 9 days until the end of June. So these highest risk individuals, 65 and older, long-term care and retirement home residents, moderate disease, really immunocompromised, and Indigenous individuals, 55 and older, and their house members are all eligible and recommended now to come for a dose. The spring bump that we had has kind of settled down, so it's certainly not as big as we had previously, but good timing for people to get their spring vaccine if they're one of these higher risk populations. I'll just speak a little bit about the fall, what we're expecting on this slide, if it's okay. And so the first thing to note is that VRBPAC, so that's in the US, it's the Vaccine and Related Biological Product Advisory Committee. So they met earlier in June, basically to decide what strain we should be looking at for this fall. And we generally try to follow along with what they're doing. They go through quite a process. So they decided that the strains for this fall should be a JN1, and they suggested that KP2, if possible, within JN1 should be the choice for this fall. At this point, it's still with the manufacturers to kind of make sure we can have those products available in time, and with Health Canada for authorization of products, but we are expecting to have a new product this fall. Whether it's JN1 or KP2, I think we don't know as of yet. And the question always is, when exactly will it be able to arrive? I think we always hope that it's a little bit earlier than it always is. Last year, the product arrived kind of right in October, so it's a little bit later than when we started to see the increase of cases in the fall. And, my fingers are crossed they might get it earlier so we can try to start a little bit quicker on the campaign. But that is what the strains we should be looking for this fall season. NACI's already come out with their fall recommendations in terms of populations, which are consistent with what we've had in previous seasons. And so we will expect a similar campaign to last year in terms of who's recommended to come in for the vaccine, but certainly available to everybody following what we've seen previously. So that's just kind of a quick update of what we're expecting this fall for vaccines. And again, the timing is still yet to be determined based on some of the authorizations for the products and when they're ready to go. So if we can jump to the next slide. Just a reminder about the updated Ontario Health Guidance. So the main differences are tightening a little bit the criteria here that antiviral treatment is strongly recommended for anyone over 65 and anyone who's compromised. Those are really the best use groups for receiving antiviral therapy, whether it's Paxlovid or remdesivir. Additional factors we consider are things like vaccination status, if no one's ever had a vaccine, really being the main thing there, and high-risk medical conditions that can all be found in the guidance that Ontario Health has put out. Next slide, please. Just running through again what the treatment algorithm is. So again, we're starting off with someone who has consistent symptoms, and then based on the timing, 5 days or less would be able to access Paxlovid if they're testing positive. If it's been more than the 5 days, then remdesivir would be the option. Next slide, please. So as of mid-May, we had the updates to the ODB formulary in terms of coverage. So Paxlovid is now available again just for individuals who have ODB coverage in some respect. And these are the 3 LU codes here. So 65 and older, immunocompromised, or having medical risk factors. And so you just put the LU code on the prescription. If someone doesn't have ODB, then there is basically out-of-pocket pay for it. Trillium drug program might be available for certain individuals who don't have ODB, depending on what their income is. But that's the case that we moved over to ODB at this point. There isn't any more broad Paxlovid availability. I know the other thing we've heard quite a lot is there's questions about, well, none of the pharmacies are currently stocking Paxlovid. And so, right now what we've seen is that because Paxlovid is quite an expensive drug, and because the demand is relatively low right now, given that we're at a kind of a nadir in terms of COVID cases, most pharmacies don't have it immediately on hand. Again, it's just expensive for the pharmacy to hold if it's essentially going to be wasted and it's going to run out. But pharmacies can order very quickly through their suppliers to make sure that they can. Pharmacies can all order through the suppliers, and they generally can get supply of Paxlovid within 24 hours. And so I know that the 5 days are potentially limiting here, which is why we really want to encourage people to come in immediately with symptoms if they think it's a concern and if they're in one of these high-risk groups, so that the testing can be done immediately. And then if pharmacy doesn't have immediate supply on hand, it's they're still within the window to be able to access Paxlovid and actually use it. Next slide, please. Remdesivir coverage is broadly available still. Anybody with OHIP, so it can be available through HCCSS if someone who's at home and if they can't take Paxlovid. So remdesivir is still quite easy to get if you need it through HCCSS for those individuals. For long-term care homes, it depends on the OH region in terms of the pathways for remdesivir, very slightly depend on the region. Next slide, please. And last one, so for testing, so we still haven't heard the final update in terms of what testing is going to look like this fall. As of now, testing is still the same. So freely available to all healthcare providers who want it through the supply portal and use the register for the provincial antigen screening program. So that's for the rapid antigen tests. Again, we're kind of waiting for the final decisions and announcements on what we're going to see for testing availability this fall. PCR tests, again, remain eligible the same way for anybody who's using the forms, can be done at some pharmacies, and those are identified in the locator here. I think that's the last slide I had on COVID stuff for today. I know there were a lot of questions on pertussis that have come up. We've certainly seen an increase in cases with a couple outbreaks. So just a quick rapid review of pertussis for everybody, unless Ali, you wanted to stop for COVID questions first.
No, you can keep going.
Okay. So we'll do a quick review here. So, pertussis is something that we still see even after vaccination programs. So, it used to be in the tens of thousands of cases a year before we had the vaccine. In Ontario, it's usually hundreds, and I'll show some of the data in a minute. It doesn't really follow a seasonal pattern necessarily like flu, but we see increases either in the summer or the fall, times when kids are kind of getting into new places together most commonly. It's very, very highly communicable. So, not quite to the level of measles, but when we looked at household contacts who are susceptible, 80% would end up getting pertussis if they have a household contact with it. Incubation period is anywhere from 5 days to 10 on average, but up to 21 days. And this is a nice one that, like, for medical school purposes, we have to review because it follows a very clear pattern. So if we go to the next slide, quickly looking at the epidemiology that we have in Ontario here, and this is all on the Public Health Ontario website going back many, many, many years. So the last year is in the top one. So we saw the whole year 333 cases in 2023. That was kind of getting back closer to what we see in pre-COVID years. So the 5-year average is artificially lowered because a little bit of the COVID, we saw essentially no cases, very, very few during the couple of COVID years. But this is getting us back to normal. So within the hundreds is normally what we would see. And this year is following along a similar pattern as what we've seen in most standard years for pertussis. The cases that we see are often we see outbreaks in under-immunized populations is when we get larger numbers, but we certainly see lots of sporadic cases in just younger kids haven't had their full series, for example. Next slide. So this is what I was talking about. So it follows pertussis follows a very classic disease pattern. So again, it's one of those nice kind of medical school ones that you can remember for trivia purposes too. Again, that first incubation period is about 21 days at max, average 5 to 10 from when the exposure is. And then first we go to the catarrhal stage, which lasts about 1 to 2 weeks. That is followed by anywhere from 1 to 6 or even 8 weeks of the paroxysmal stage, and that's kind of the most severe in terms of symptoms. And then finally convalescent stage, which can last months until symptoms disappear ultimately. And that most communicable is really from the start of that catarrhal stage through the first couple weeks of the paroxysmal stage. So if we can go to the next slide, please. The catarrhal stage is basically undefined URI sort of symptoms. Runny nose, fever. In infants, we do sometimes see apneic episodes, which can be a little bit more of a hint that it's something more than just a standard URI. But really, it's general symptoms. But in this early phase, if we are able to identify it as pertussis early on, we can actually give antibiotic treatment and stop from an ultimate progression to the more severe symptoms. That usually happens if someone's a contact. Otherwise, again, it's very difficult. You can't really clinically distinguish this from other viral upper respiratory illnesses that we might see. But we do see this early phase first. Next slide. So the paroxysmal phase is kind of the classic whooping cough phase where we hear that whooping sound. And this is where coughing becomes more severe. People get those repeated cough episodes, vomiting from the amount of coughing they're doing, exhaustion because of so much coughing. Attacks tend to happen more frequently at night, but an average of 15 attacks in 24 hours, which is quite a lot in terms of coughing attacks. The first 1 to 2 weeks of this phase, we see a slow increase in the number of cough attacks that you'll have. and then they kind of stabilize for the next few weeks until they're out of the paroxysmal phase entirely. Next slide, please. I found just CDC has a what's that sound for what a whooping cough sounds like, and since I don't think I've ever heard one in clinic personally, I think it's probably helpful to run through. So I don't know how to play the video, but if we can go ahead and just play it, hopefully people can hear.
Yeah, we
Nope.
can see it's possible it might not work. Yeah, it's
Okay.
not playing, unfortunately, but
No problem.
that's okay.
It's in here and everybody can find the link, but it's that classic whooping sound. I'm not going to try to make it myself, but you can find it on YouTube, and it's again it's pretty distinctive in terms of hearing that whooping cough. So next slide, please. So the final phase is that convalescent stage. This is where people have slow recovery. The cough fits tend to disappear over the first few weeks, but it can be sometimes months until really the final end of symptoms entirely for pertussis. So next slide. Contact management. So we do have contact management. So it is a disease of public health significance. It's notified to local public health authorities. Contact management isn't about reducing, the broad changes in outbreaks necessarily. It's really for close household contacts or very, very closely defined exposures for especially vulnerable infants, so really, really young kids, less than one, or pregnant individuals, to make sure that those at highest risk are protected from potentially getting whooping cough. So you should do it as quick as possible, but you can do it anywhere in that first 21 days after contact before symptoms start. And then afterwards, treatment would be suggested instead of contact management prophylactically. So next slide. And so this is just a quick list. This is again from the Ontario Public Health Standards appendix on whooping cough. This is antimicrobials you would use for chemoprophylaxis. Similar ones that we'd use for treatment. So, for adults, it's that Z-Pak is still very effective, what we see. And then for younger kids and infants, it's just weight dependent in terms of how much you would be using for treatment. Next slide, please. And so lastly, just a reminder of what the schedule is for Ontario. I just cut and paste myself to put just the pertussis parts in here. So as a quick reminder, so the within the first year and a half is when you get those first 4 doses. The 2, 4, 6, 8 months are to protect against pertussis. Then we have the 4-year booster, and then we have 14-year booster, and then once more in adulthood. So it's on at 24 years, but that dose is, again, anytime in adulthood if someone hasn't had a DTaP after they're 14 yet. And the last one is every pregnancy, ideally between weeks 27 and 32 of gestation. Pregnant individuals should be getting a dose. That is to protect the infant. So that would be the pregnant individual basically getting antibodies that are going passed through placenta and then breast milk to the infants once they're born, so they have protection against pertussis for the 3 to 4 months after birth. I think that's the last slide I had here, so we can head over to questions, Alec.
Awesome. Thank you so much for that amazing overview and reminders as well too, all super important. And I noticed that we lost our second co-panelist with you as well. She was very popular, so
she was getting hungry. It's best that she has some tea.
Fair enough, fair enough. And she's welcome back anytime, of course. And I think I saw a lot of participants express that as well. So we'll move to Q&A. So the first one here actually is one that you already answered, but I'll just restate it. So it was around the stocking issues in the pharmacies, and so just a call for better advocacy around advocating for the pharmacies to have it in stock. And it was helpful to hear from you about the process that they are able to rapidly source it if need be. And then the other question that came up is whether or not we can still fill in advance of an infection. Is that still a process that you can send a script in advance or no?
So for the LU codes, I think I had the language that the LU codes require a positive test to use the LU code. So for those, you couldn't really send an advanced prescription to be filled. If it's out of pocket, and I will double check on this one, but I think for out of pocket pay, that would be one that doesn't have that requirement in place, but I can't confirm and get back to everybody on that.
And what about the process? Because I just recall this was happening at one point that you could send a script and then the patient would have to present the positive test to the pharmacy in order for it to be filled. Is that still a process or no?
For the LU code, I believe that is still the case. So again, the LU code requires a positive test to be filled. So you have to make sure that those criteria are met. Again, that can be in any way. It can be a picture, it can be whatever. But to use the LU code, you need someone to be positive already.
Yeah, exactly. Yeah. I just think that might potentially help avoid the delay, right? Versus having to call the doctor's office to get it per se. And I know some of us were sending scripts, in advance. The pharmacy would hold on to it, tell the patient, just present your test to the pharmacy and they'll fill it for you, right? So we can clarify that though, and maybe send a message out to confirm that.
Yeah, for sure. But yeah, like you said, you can keep that prescription on file. It's just, and then if you're giving out the rats for the person to take home, they can kind of come in and fill it with the positive one. If it's the LU code, and I'll confirm for the private pay what the case might be.
Awesome. Thank you for that. In terms of another question here, so if we no longer have access to rat testing for free, how do we diagnose in the community as family doctors or even as patients at home?
So the access to rats is still available for free right now. And so it hasn't changed. It's still through the provincial antigen screening program. You can order through the portal. We're just waiting on the fall what this decision is going to be. So I don't know what the answer is to that one for the fall yet. We'll see what happens, and we'll have to see where we go from there.
Thanks. I see here some people are expressing perhaps some difficulties with accessing it once they put in the orders. So definitely, something to let us know about, and perhaps something to follow up on as well. And then the other thing that came up too, just in the chat that I noticed that I wanted to highlight is that someone had mentioned the Can Treat COVID study as well, which we've presented before. It's a randomized controlled trial that is looking at different treatments for COVID-19 and especially for prevention of long COVID. And through that, they can access testing as well. So potentially, you could refer a patient to that program, if they've been diagnosed with it, or if you're looking for access to treatment and they can't get it per se from their pharmacy, the Can Treat COVID study could be another option to get someone access to treatment as well. So just wanted to throw that out there too. And then in terms of another question here is, any plans for Novavax vaccine rollout in the fall? Previously, it was only available at certain public health clinics.
Yeah, so again, this is going to depend on timing of product and availability. So, we have heard from Novavax, they're planning to have an updated strain. Last year, it just came quite delayed was part of the issue. I don't think the Novavax arrived until almost December. So we were kind of through most of the campaign, which is part of the issue. Fingers crossed that it's coming earlier and we can have it up front with part of the general campaign with the other products.
Thanks. And then another question here about wastewater sampling. So I know we talked about this a bit last session, but can you just restate for us, Dan, in terms of what's the plan with that in Ontario moving forward?
Yeah, so the wastewater program has been canceled. It was quite an expensive program, and so that was really part of the considerations. Basically, at this point, there was a discussion about, well, what's the additional utility of wastewater beyond the other metrics we have, percent positivity, reports to ED visits, hospitalization, ICU, positive cases. And given that we're not making public health measure changes at this point, having potentially a few days earlier notice from the wastewater, is generally giving us maybe 5, maybe 7 at most days earlier than we'd see the increase in actual percent positivity. We weren't really doing anything necessarily with that information like public health measures. So it was a question of, for the expense and the cost of that wastewater program, what we're getting out of it. And, finally, the decision that was made was that we probably weren't using it enough to warrant the cost at this point. There are still some local public health units might be doing wastewater. There's certainly researchers that are still doing wastewater assessment. And so there might be more local findings as well. And wastewater is still being used for some other diseases that we're tracking, like Mpox, for example. And so it's really about using it in a situation that makes most sense because it's quite expensive.
Mm-hmm. Thanks. That's helpful background to understand what goes into those decisions. So thanks for sharing that. Another question about COVID. So what do we know at this point about the long-term effects of multiple bouts of COVID and, between young and healthy individuals versus perhaps people who are not so healthy, elderly? Do we know more, or has that understanding changed a bit more?
It's come along a bit, and I'm not the expert in this one. I think you've had some better people than me for that, but there have been some studies suggesting that multiple cases of COVID are leading to a little bit of a faster time for diagnosis of things like diabetes or some heart disease. We do know some people have COVID and get those really systemic inflammatory effects. The problem at this point is it's hard to say if that's an everybody thing or certain at-risk individuals. And it seems like it might skew more towards certain individuals just happen to have either more severe infection or for whatever reason are more at risk for those systemic effects following COVID infection. It certainly does appear to be more often that we're seeing that in older adults as opposed to younger, healthy individuals. But that also is skewed because older adults are more likely to be diagnosed with diabetes and heart disease in the first place. So I would say we're still learning quite a bit about it. There is something systemic that's happening to some individuals in terms of developing these other illnesses as a result of their COVID infection, or probably we should say faster as a result of their COVID infection. People are probably on that path in the first place, but we're still learning quite a bit about it.
Amazing, thank you. I'm going to close out with a couple questions about pertussis, and then we'll move on to the next speaker. So first question is, should we vaccinate dads and caregivers of newborns with Tdap?
So if they haven't had their adult dose of Tdap, absolutely yes, they should. We want to make sure they have that lifelong protection, and so they're not going to be at risk. Again, the primary reason for getting that Tdap in every pregnancy is antibody protection for the infant. So if the dad, other caregivers have had their adult dose, we're not really worried at that point about their level of protection or that they might spread, as long as they've had that one adult dose at some point.
And that feeds well into the next question, which is, why is Tdap only recommended once as an adult?
Yeah, so again, that adult dose we see provides really excellent protection throughout the life course once you're older. So we're not seeing the need for additional booster doses after that point if you've had the adult dose.
And does that differ for healthcare providers at all? Do we need to be more worried or anything like that?
No, again, unless you're someone who's immunocompromised, have other health conditions that put you at higher risk, that potentially is a different story. But for a healthy person, solid immune status, there's no reason to have additional boosters if you've had all the recommended ones.
Makes sense. And then last questions here are about pertussis testing. So how do we test for it? Do we need to test? And how long does it typically take?
Yeah, so PHO has, we can probably put the link in the chat, has their full test algorithm and their test information sheet for pertussis. They generally run it only from Monday to Fridays at the lab. It's not one of the more urgent ones that they're doing on the weekends. So it takes, if it comes in quickly, it can be 24 hours. Up to 4 days is the turnaround time that they're quoting for pertussis testing, which is still reasonable in most cases. Just again, the timing is weeks that you'd be in a certain phase of pertussis. So it usually still gives you results quick enough that you can do it. And so again, all the details for testing are on that website. And so I encourage people to go there to make sure. But it's basically the same PCR testing that we'd be using for other respiratory illnesses.
Amazing. Thank you. Always such a pleasure having you on, Dan. And there are some more questions in the Q&A if you do want to answer those in writing as well. But otherwise, I'll turn things over to Dr. Wong to speak to the next slide, and then we'll move over to Dr. Wyman.
Great. Thank you. Yeah, so this is a reminder. I think we just talked about this, the Can-Treat COVID RCT. If you have patients who are recently diagnosed, please consider referring them to this study. And I do want to advise you of 2 initiatives that are looking for family physician expertise and participation. The first one is the Ontario Health's Patients Before Paperwork Clinical Advisory Table. And I think the name of this committee really speaks for itself, and the deadline to apply is July 6th. The second one, the Practice Ready Ontario program. This is a Ministry of Health funded program administered by Touchstone Institute, and it uses an accelerated 12-week assessment program as a pathway for internationally trained physicians to obtain licensure here in Ontario. Currently, the program is assessing internationally trained family physicians and general practitioners. There are currently 8 other provinces that are running these practice-ready assessment programs, and some of them do assess for specialist licensures as well. The program is looking for individuals who are interested to participate as members on the assessment committee that makes decisions on the outcomes of the 12-week clinical field assessment, and the appeals committee that will hear any appeals that may be launched by any candidate who may be unsuccessful in their assessment should they have any concerns with how they may be assessed. I also happen to be the clinical director for this program, and obviously you can reach out to me should you have any questions. The team at Touchstone Institute will be more than happy to answer your inquiries.
Wonderful. Thanks for that, Dr. Wong. Over to you, Dr. Wyman.
Good morning. Thank you for having me on this morning. It's a bit of a jump. There's no segue I can make from talking about pertussis and COVID to alcohol, except we're moving into summer. Next slide, please. So these are some of the questions that came up in the pre-survey that I hope to cover, and obviously anything else that we add to the Q&A. Next slide, please. Maybe click again so that we can see the actual guidelines. Thank you so much. So I would hope at this point, lots of people have seen this graphic coming from CCSA. It's been published in CMAJ and it's been all over, and it's been pretty controversial in an interesting way. A lot of clinicians who've been practicing for a while were pretty familiar with the previous guidelines that sort of had what I think people took away as being a safe and an unsafe amount to drink. And people used, or I would say misused, those guidelines to make an assessment of whether someone had a problematic alcohol use or not. So over 15 for men, over 10 for women was considered, this is a flag for something. And this is really a shift. It is more, I would say, like kind of an RDA approach, in the sense that if you think about it as being guidelines around how many grams of trans fats we should have, or carbohydrates and refined sugars, we know that there's an increasing risk with increasing intake of certain things that aren't good for us. It doesn't mean that we can't have them at all. It doesn't mean that we have a disorder if we have more of them than would be healthy for us. But there's some kind of relationship between intake and potentially unhealthy outcomes that, of course, is moderated by other kinds of factors. So it's true, even though, many of us may like alcohol and enjoy it, that it just isn't really good for us. And the older studies that seem to indicate that there was some protective effects from lower amounts of alcohol have been pretty much debunked. So what this graphic means, and it's really derived from public health data and modeling, looking at what are the outcomes on mortality across populations, is that the only way to know that there's no negative outcome from alcohol is to not consume alcohol at all. That doesn't mean that consuming any alcohol is either going to put you at risk for health outcomes or means that you have a substance use disorder, but to try to help people understand that with increasing intake, there are increasing risks. And it's been very difficult, actually, to try to translate this public health oriented messaging to working one-on-one with patients. And that's a little bit of what we've been trying to do. And I hope what we can talk about a little bit more today. So next slide, please. Why the new guidelines? There are a bunch of methodological reasons that aren't that interesting, I don't think, but we can talk about them if you like. But basically, alcohol is a carcinogen. And it's now shown that there's no lower threshold in terms of its potential contributions to cancers of the oral cavity, pharynx, larynx, esophagus, colon and rectum, liver, and breast cancer. And it's also a risk factor for most types of cardiovascular disease, as well as a host of other concerns, injuries, accidents, violence, including both partner violence and sexual violence, both as perpetrators and victims, liver disease, which is very significant. I'll show you a slide about that in a moment. And then other things that don't necessarily affect mortality. They haven't been sort of added into this guidance, but obviously sleep issues, headache issues, endocrine issues, including osteoporosis. So lots of conditions are linked to alcohol use. Next slide, please. I know this is really difficult to look at, but lots of people have asked, does it really matter in that sort of, lower quantity drinking per week in the 3 to 7? How much of an impact is it having on health, and how worried do we need to be about that? And this difficult to read table shows you the number of drinks per week across the top. This is for men. Increased risk of diseases and injuries associated with weekly alcohol use. And again, this is sort of pooled from many different studies looking at grams of alcohol intake and average. And you can see that between 3 and 7 drinks per week, there are already increases in certain types of cancer, cancers of the oral pharynx, the larynx, pancreatitis, increases in the risks of liver disease and cirrhosis, well under 7 drinks per week. And then increases in injuries, road injuries and unintentional injuries as well. And if you turn to the next slide, please, which is similar data, but for women, we look at the risks of breast cancer, and we can see that at 7 drinks per week. Sometimes we say as an average of a drink a day, but of course, people don't always, spread their alcohol evenly over the course of the week. In fact, it's much more common for people to have non-drinking days and then, days of drinking or heavier drinking. That the risks of breast cancer really start to increase at an average at 7 drinks per week, and at 14 drinks a week or 2 drinks a week or more, the risk of breast cancer is increased by more than 25%. Why am I saying 2 drinks, a day or 4? Just to remind everybody that a bottle of wine is 5 standard drinks. 5 glasses of wine. And so when people talk about sharing a bottle of wine on a nightly basis, that's 2.5 glasses right there, and it may or may not be evenly shared between partners. It's not uncommon for us to hear about people who, open a bottle of wine and it's gone pretty regularly. So, of course, there are people who are consuming no alcohol, people who are consuming alcohol in clearly unhealthy and problematic ways where they really are not in good control of their drinking. But for the purposes of this conversation, we're not talking so much about, making a diagnosis of a substance use disorder, but really of thinking about what the impacts of alcohol are on health generally and how we can encourage people to think about their intake, what the implications may be, and how they might feel better or want to engage with drinking a little bit less. So next slide, please. That's where our role as primary care providers is in really making those connections between how people are feeling, what they're coming in to us discussing, and thinking about their alcohol intake. So again, this is not about, or it's beyond actually sort of a form on your CPX box ticking off that you've screened someone for alcohol intake. It's thinking about how people are complaining or having challenges potentially with their sleep or headaches, as I mentioned. We think about blood pressure, we think about mood, classically people who are not having the expected response to their medications or other supports for mood and anxiety. There could be people where, you're looking at their lab results, right? And liver enzymes are a little bit up, MCV is a little bit up, a host of things that we see in primary care that are an opportunity to think about raising this as an opportunity for conversation and suggesting that alcohol may be playing a role in how they're feeling. And really importantly, trying to reframe it as the hope that they actually might feel better and notice positive outcomes, because people tend to get very resistant when you talk about taking away something that they like. But when you encourage them to consider making changes and see whether it has a positive impact on their sleep, on their blood pressure, on their mood, or on their energy, then we're much more likely to be able to sort of coach someone. So there are those two sides, right? We sort of use sometimes the fear factor around cancer risks. And I think that this has really been the case with talking about breast cancer in women. And it's potentially problematic because it can increase this sense of guilt, actually, when people are diagnosed with a cancer associated with alcohol, that somehow they're to blame. So we don't want to do that either. So if we look at the next slide, the goal is to help people think about their own targets and what makes sense given the rest of their overall health condition. So clearly in people who are pregnant or breastfeeding, the goal is to have as little alcohol as possible, and 0 is really the only amount that we know that is safe. As people get older and have multiple health conditions or medications that interact with alcohol, we really want to be thinking about lower amounts, and lots of just easy strategies to help people think about setting goals and sticking with them. So again, if we think about aiming for a maximum of 7 drinks a week. I don't actually say 3, I say between 3 and 7, although of course people are welcome to have 0 and some people will have more. Then the way to do that is really to make sure that people aren't drinking every day. So choosing which day of the days of the week they'll drink, pre-thinking about how many drinks they're planning to have, making sure that people are eating and drinking. Drinking on an empty stomach, obviously you get more of an alcohol hit in terms of the effect, but it's also harder on our liver in terms of metabolizing. And we know that spacing alcohol and eating it with food actually is helpful in terms of the liver effects, particularly with women. One of the things that I think is really important is to help people look at how they drink and how ritualized or habitual it's becoming. So for some people, they walk in the door and they're pouring a glass of wine. And so if their intention is to try to reduce the amount that they drink around that time, they're going to have to really reset some of those habits, much like we do when we're trying to coach people to quit smoking, right? We say you can't sit down with the same newspaper and cup of coffee without the cigarette and think that that's going to work so well. So creating a new pattern or a new activity when you come home, going for a walk, having a different kind of drink. Another really common pattern is people having a drink when they're feeling really anxious. And that's a really important one for us to look at too, in terms of the connections between drinking and mood and anxiety that we'll get to talking about a little bit. So next slide, please. One really important medication, when people say that they're interested in reducing their drinking, but they're having a tough time, they've already made some efforts, they're having thoughts and urges, you identify that they're drinking well above what is really a healthy amount, and you're interested in offering them an option. Naltrexone is a medication that every family doctor should know about and can easily prescribe. You don't need any extra training for it at all. It's not a medication that makes people feel sick if they drink. It blunts the euphoric or pleasurable feelings of alcohol. And so it helps to reduce those cravings for alcohol, and it helps to reduce the results if people do drink. So it's primarily intended for people who are looking at reducing the frequency or the quantity of their intake, but it's also helpful in people who want to stop drinking. You can start it in people who are still drinking. That's really significant about it. So people come in and they're drinking more than they would like, or in ways that you think would really benefit from a reduction, they start naltrexone. Usually we say 25 milligrams a day for the first few days, just in case there's some nausea or headaches, and then going up to 50 milligrams a day. And that, again, in conjunction with your coaching and thinking about their patterns and their habits around drinking, can be really helpful. You don't have to order liver enzymes before you start it. It's nice to have it around the onset. It's not contraindicated in people who have elevated liver enzymes because likely their enzyme levels will decrease if their drinking decreases. But it's good to have a level early on. I wouldn't use it if they had full-on cirrhosis or liver enzymes were more than 5 times normal. If they have elevated liver enzymes to start, we like to repeat them between a month or a month and 2. And then coach them, see them back again, just as you would if you were coaching someone around smoking cessation, or you were managing hypertension and you wanted to see people back to see what their numbers were looking like and how they were doing overall. Next slide, please. One of the things that you may have heard about is something called the Sinclair method, or taking naltrexone on kind of an as-needed basis. It's sort of like pill in the pocket in a way. Not everybody wants to take naltrexone every day if they don't drink every day. Or sometimes people who've been on naltrexone for a while and been really successful wonder, do they still really need to take it every day? And in people who do have alcohol use disorder, we recommend taking naltrexone or other medications for pretty much a solid 6 months before really discontinuing. So the idea of the Sinclair method is that people can take naltrexone when they know they're going into a situation where they're going to be exposed to alcohol and they want to have something extra on board that helps them. And it's psychological, but it's really physical as well, in meeting their own goals of really managing it and moderating their drinking. So ideally, it's taken an hour or 2 before that exposure, because that's when we see peak blood and brain levels at around that 2-hour mark post naltrexone. And it can be really effective. So it's a nice kind of tool for people. You could think about it as a bit of a harm reduction approach for people who aren't interested in taking medication all the time, but want that extra sort of protective layer overall. Next slide, please. Really important to remember that medication is not everything, as with so many of the other conditions that we treat with people. What's new is that there are all of these other groups in addition to 12-step. AA is actually making a resurgence, I would say. There are lots of people recognizing that the mutual support, the recovery orientation, having the social networks and models of people in long-term recovery is really helpful. And there are lots of AA groups that are not sort of religious focused, that are specifically atheist or agnostic or Buddhist or Zen or LGBTQ positive. There are also groups called Smart Recovery, which have a more CBT kind of approach to substance use, a group called Women for Sobriety, specifically for women, that really recognizes and highlights the connections between trauma, women's experiences, and substance use. I just want to mention a group called Families for Addiction Recovery, because I think that's important. As family physicians, we're often providing support for the families. This is particularly for families with youth who have substance use disorder, that has lots of resources, again, and mutual support. And then so many great podcasts and apps for people to use to help track their substance use, and of course, to think about mindfulness as a really important tool too. Next slide, please. You may have heard from some of your patients about semaglutide and effects on alcohol use. It's really interesting. There have been studies going on in rats for quite a while. Part of what's interesting is that there's this whole new research model, which is looking at social media posts. That's where some of this information has come from, and people all commenting about their decreased alcohol intake and cravings for alcohol being on semaglutide for weight loss or for diabetes. How does it work? It looks like, in addition to all of its glucagon-like properties, it has effects on dopamine release in the striatum as well. So dopamine is that feel-good chemical that's kind of the net neurotransmitter for all of the things that people enjoy, but also can get into trouble with, whether it's alcohol, opioids, I'll say sugar as well. And so semaglutide seems to have an effect on the dopamine release there as well. I'm not suggesting that people prescribe it to help people whose alcohol use is high. In fact, there's an interesting thing where it looks like it may be helpful in people who have obesity, but people who are not obese who are taking it actually may seem to have an increase in alcohol intake, and nobody knows why. But just to sort of have it on your radar if people are asking about it, and maybe ask people who are on these medications whether they're noticing any change in their intake, and use that again as sort of a talking point about or around what they were drinking, what their intake is like now, and what their goals may be. Next slide, please. Another current topic is SSRIs and AUD. And I've shared this reference. The Canadian Guideline for Clinical Management of High-Risk Drinking and Alcohol Use Disorder has a number of recommendations. It's great to go through. It looks at anti-craving medications. It looks at algorithms and pathways for supporting your patients who may need help with withdrawal management. These are the two that have to do with SSRIs that have raised some questions and some controversy. I think the first is really easy to understand. We should not be using SSRIs as treatment for AUD. We have evidence-based medications that work for AUD, and those would primarily be naltrexone and acamprosate, and then a number of other medications that are also used, gabapentin, topiramate, for example. The more sort of challenging or difficult one is recommendation 13, that recommends against prescribing SSRIs for adults and youth with AUD and concurrent anxiety or depressive disorder. And I would say that there's a lot of discussion and disagreement in the community of people working in substance use disorders. And I would maintain, and I think many people would, that we need to treat both conditions. So again, medications are not the sole answer to mood and anxiety disorders. And if we could get everybody CBT or DBT, that would be great. We should be looking at the non-pharmacologic approaches. But when someone is working at decreasing their alcohol intake, and they're still struggling with an obvious anxiety or mood disorder, we should be using the tools that we have, including first-line medications to treat those tools. We should be watching carefully. If it turns out that someone actually seems to be experiencing increased cravings for alcohol or increased intake after we've added an SSRI, then maybe that's not a good thing. But we can prescribe and co-treat these two conditions. I think we spent a long time trying to move away from the model where psychiatry said we can't treat your mood disorder till the substance use is under control, and substance use said we can't help you till the mood is under control. So I see this as a bit of a step back, and I would encourage people to keep thinking about what the sort of concurrent issues are and how to address both, and ask for guidance if you're not sure what the next best steps are. Next slide, please. One of the great things is that there are lots of people who are drinking a lot less, and there are lots of products to help support them. So I guess this is tied into the theme of the summer, which is load up your coolers. You can find all kinds of great non-alcoholic mixers online if you're not in a big city. There's some great beers. I wouldn't encourage people to think that a non-alcoholic wine is necessarily going to have the same feel on the palate. But there's a Guinness Zero, a Heineken Double Zero, a Corona Sunbrew. People who like beer find that it's really nice to have something that has a bit of a taste and mouthfeel. Even people who drink wine and are looking for something to replace that often enjoy these. Google recipes for mocktails. There's so many great options, including ones that are really low sugar, so you're not just replacing that. And enjoy and have a great summer with those. Make zero alcohol options really available all the time, not just as something that someone has to sort of go searching for or looking for. And next, and I think last slide, if you've tried implementing all these things, your patients are having a tough time, and you think that they need more support, remember that there are now rapid access addiction medicine, or RAM, clinics across the province. The directory to RAM clinics near you is found on the Medify website, medify.ca. I think that's in the resources in the chat. There are also lots of other great resources there for clinicians around supporting patients, and also a bunch of new patient-oriented resources that we hope are helpful. Happy to take questions.
Great. Thank you so much, Dr. Wyman, and a topic that's very near and dear to my heart as well, too, as a fellow practicing addiction medicine doc as well. So thank you so much for that. And what we'll do, just so we can get the core content done before 9, is I'm actually going to turn things over to Dr. Chan, and then I'm going to do a combined Q&A for both of you. So I'll move things straight away to Dr. Chan, and then we're going to come back for a Q&A.
Right. Thank you so much. And good morning, everybody. I'm actually wondering if folks listening could quickly write in the chat, what are your favorite ways to rest and enjoy the summer? I would just love to hear what people's favorite ways to spend the summer resting and relaxing are, not for comparison, but for inspiration and celebration, because I would love if, as a medical culture, we shifted to celebrating each other's relaxation and enjoyment more. Next slide, please. That's what this whole talk is going to be about, is how to have a spacious summer, how to really actually be thoughtful about how we plan our summer vacations. Why is it important? Because everyone who's currently typing in the chat, getting ready for their clinic, driving to work, all of you are human beings with human bodies, and our human bodies do well. In fact, it is essential that they experience rest and they experience pleasure. Those are like fundamental truths about us as human beings and human bodies. And yet we kind of forget those because of what's on the next slide, please. Why is it so hard to remember rest and pleasure are essential for all of us as human beings and human bodies? We have a deeply work equals worth social culture. Certainly inside of medicine, it's tied to service equals worth. So how many patients you see, how much you work, how many, oh, I've worked 50 hours, I work 60 hours, maybe I'm finally a good enough physician. Like, this kind of socialization runs deep in our bones. And it means that if we consider resting, now we feel guilty. Now we think we're selfish. Now we think that we're lazy, all these horrible terminology that's based in like a shame-based culture. And that's why it feels hard, right? On top of that, reinforcing that culture, we currently work in a healthcare system that is not designed with our human bodies in mind. Otherwise, we'd never have a system where one human is solely responsible for a number of other humans, which is the current model most of us work in, either in the hospital when you're on, and certainly if you're an outpatient family physician, you're the most responsible physician all of the time, apparently. That's not a system designed with human bodies in mind, because human bodies get ill. And also human bodies need breaks. And that's also why, just a self-reflection note, is what happens when you try and rest What happens when you try and do things you enjoy? When you go on vacation, how long does it take for your body to actually allow you to unwind and settle? That is the detox, if you will, speaking sort of in a parallel to the last talk, the detox of that hyper vigilant, hyper focused, overworking feeling that we often feel like we have to do when we're in our workplace. Next slide, please. I'm loving seeing all these in the chat. They make me feel relaxed to read them, honestly. So I want you to remember, when you are resourced and rested, which pleasure is a resource and rest is essential, you make less distracted mistakes. You have more mental, emotional, and physical bandwidth to show up at work when you next go to work. When you are at work, you do more creative decision-making, which in these troubling times where we are under-resourced and understaffed, we need to be very creative in our decision-making on a regular basis in medicine. And the last thing is you don't leave medicine. There's sort of this paradox of like, no, there's not enough family doctors, so I can't take vacation. But if none of us take vacation and we are all at a point where we're leaving medicine because we've just gotten so burnt out because the system doesn't support us, doesn't mandate us to take vacation, doesn't actually celebrate or pay us in any way to take vacation, then we leave medicine and then the problem gets worse, right? Next slide. So this is my sort of tip of a strategy that has worked well for me that I learned from mentors and colleagues. And I tried to show it in pictorial emoji form. So on the left is what often we try to do. So we have our regular not feeling so great work weeks. Then the second week there is us feeling super stressed because we know we're about to go on vacation. So we're actually trying to cram things in. We're fitting in more patients because we feel guilty that we won't be there next week. So we're extra stressed. We finally have a week where we're trying to be on vacation, though underneath those sunglasses, we might still be thinking about things, or maybe we've brought our laptop to the cottage and we're still checking our inboxes, but we're trying to relax at least a little bit. And then when we come back from that vacation, then it's like dead eyes, because now that mountain of the inbox that we didn't check when we weren't on vacation is with us, and we regret going to begin with. That makes it hard to actually get the restorative impact of that vacation, right? And so on the right is it's a very classic strategy. I hope most of you are already employing it in some ways, which is you see those little like just sort of flat faces, a couple days, at least a half day, but I would say 1 to 2 days before and after vacation week, lightly book and actually don't book. Because I don't know, when you go on vacation, there's like stuff you have to do to prep for that vacation, like packing and buying things. Creating space to actually do that instead of trying to jam it all in is, first of all, just practical. And it allows your body to slowly like transition out of work mode into, instead of being human doing, you're transitioning into human being mode. Then when you're actually on vacation, please leave the laptops at home. I just, as much as possible, and if you really can't, message me, let's problem solve. Like this is something like, can we all actually have a completely work-free week? I believe we can, even if we're not supposed to. I think it's essential that we do, and the system has to change by us doing that so that we actually can have time away from work and remember that we're human beings outside of work. And then on the week you get back, either half book or lightly book, or don't book at all the first few days. Most people, certainly in my office, including myself, do a paperwork day. So we're catching up on inbox, and then we start seeing patients for the rest of the week. And so then see those little happy nerdy selves? Perhaps we can actually remember what we love about medicine to begin with. A really effective vacation. I know I've sort of done this process in a way that felt good for me. When I come back, and even my trickiest patients, I can just smile at them a little more and be like, you're doing your best, aren't you? And it just feels so much better to remember why we signed up for this wild career to begin with, right? So next slide, please. And remember, so like the reasons why you might be like, that sounds good for you, but I can't. I have so much to do. Just a reminder, the amount that we are supposed to do as family physicians is like literally impossible. They've done studies about how the number of guidelines we're supposed to do is more than the number of hours we have in a day, plus all the other tasks that we're meant to do. So doing it all is impossible. So we all just get an F on doing it all and we can move on with our lives. And anything you do, say you get back and you see 2 patients, that's 2 people you helped. That's amazing. Anything you do is valuable and more than enough. You are enough as a human being, even if you see no patients. And actually practicing this by not seeing any patients for full weeks or multiple weeks at a time is really helpful to detox from this really harmful shame-based socialization we're all in. Next slide, please. So some practical ways to try and create the spacious summer. This is the same framework you may have seen me do before in terms of how to actually make sure we're working below our capacity. So it's a great time in the summer to think of what you want to pause or just straight up quit. What do you want to take a summer hiatus from? That committee that you're not actually that big of a fan of anyway, that task that you hate doing, basically whatever you hate the most. What happens if you don't do it for 2 months? Does anyone actually die? Mostly not, honestly. And also just regular follow-ups. For me, I have some patients where I kind of get into a routine of codependently seeing them once every month. Summer's a great time to be like, hey, let's stretch it to 2 or 3 months. See you in the fall. And then they also realize, I actually don't need to see my doctor that often. I'm a capable person on my own. So it's sort of therapeutic for everybody. Delegation, that's a common one. And so expanding what we think of as delegation. Of course, many of us try and find a locum, even expanding who we think of as a locum. Myself, I employ nurse practitioners who are my locums, and that works very well for me. Say you cannot find a locum to do all of your seeing patient work. Could a locum at least cover some of your inbox? There's more and more like inbox specific locums popping up. So that's an interesting thing to explore. Understanding that our colleagues are often there for us and we can trade off with each other, and celebrating that we do that for each other. And honestly, like say you can't find anyone to cover for you, and instead your patients go to all the walk-in clinics and all the emergency rooms and all the places they're not supposed to go and you're supposed to feel bad about. That means that those people got seen, they got treated, and that you don't have to do it when you get back. What if we start to celebrate that? We budgeted into, yes, that means it's a ding to our access bonus. We budget that into our vacation budget, but it means we didn't have to see them. It means we still take a vacation. What if that's not a barrier to taking a vacation, right? Really, that lower right quadrant, what is it that's essential to protect? Scroll up and look at the thing that you know helps you feel rested and relaxed. How can that be the thing you prioritize and protect this summer, both when you're on vacation, but also like on half days off, on weekends? If that's what you know helps relax your body, how can that be prioritized in this summertime? And everything else, bare minimum. Let's celebrate mediocrity, folks. Let's celebrate that good enough is good enough. Done is better than not done. And just like, look at one thing at a time and then move on. So those are some ways that I really try and separate myself from my work, try and do good work when I'm there, but remember, I'm a human being outside of my work as well. Next slide, please. This is from a fabulous book called Rest is Resistance. So also a reminder, if you're someone interested in advocacy, activism, change, system change work, that quiet quitting, if you will, taking the time you need, whether the system supports you or shames you for it, is an act of activism, and rest and is a radical act in a world that's only values you based on what you do for others. So as it says here, rest is a beautiful interruption in a world with no pause button. You will not lose it all if you pause to connect with your body and mind. You have already lost it all if you're living in a fear-based life centered on scarcity, which so many of us are socialized to do. Do not fear what you are missing or losing. You are abundant. Your rest is abundant. You are more than what you produce for a capitalist system. Your worth is deep. You are safe. This is a whole deck you can get. So if you just need to read those as you detox from overproductivity culture, feel free to look up this rest deck. Next slide, please. So final reminders is when you are on vacation, what if you had a very spacious and under-planned vacation? What if you plan very little and you allow each day to flow one day to the next? Most of us still bring our type A personalities to our vacations and try and cram in the most. And if your body thrives on that, that's fabulous. But double check if also your body would love a little break, a little lie, a little hammock, a bunch of naps. I didn't do enough on my vacation, I hear people say, and I'm like, that's how you know how deep the socialization goes, right? And then the other piece is, again, scrolling up to what you know brings you rest or pleasure most. How can you start to incorporate those activities or the idea or feel of those activities into your daily work before or after clinic, ending clinic early so you can go do those, especially in these sunny days? The more that we practice rest and pleasure in our day-to-day lives, the easier it is to sink into it further. It will feel less foreign and unfamiliar when you are on your vacation. If you're interested in these ideas, that's my Instagram. I have a podcast, and thank you so much for listening.
Great. Thank you so much for that. Really great reminders in terms of making sure that we think of ourselves as human beings and, take that into consideration, especially when, we recognize that in the summer we also need time off and we need to respect that as well. So thank you so much for that. It was really, really great messaging. And so I'm going to ask a few questions in the Q&A, and just a reminder for our attendees, we try and get our core content done like we did today by 9, but we can extend till 9:15 just for additional Q&A, which we'll do right now. So the first question actually is for Dr. Wyman, if she can come back onto the video. Perfect. So the question here is, how would we manage someone who was who's going in, let's say, for a colonoscopy or for blood work, and they need to fast for 12 hours, and they have a history of an alcohol use disorder, heavy drinking, and there's concern for withdrawal? Do they need to do those procedures in the hospital setting? Is there any advice that you give them in particular in that scenario?
That's a good question. I would ask that person what their own experience of withdrawal has been. So it's true that people can start experiencing withdrawal within 5 to 6 after the last drink, depending on how much they drink and how frequently and intensively. Most people don't need to fast. I mean, don't need sort of management of withdrawal for unless they have really severe alcohol use disorder and a history of seizures or complex withdrawal, just to get something like blood work done. I would encourage someone whose alcohol use is that severe to try to start cutting down in the week before and work with them to maybe set some targets around how much they're drinking. That might be an okay time to use some naltrexone to help them reducing a little bit. We also didn't talk about this in the presentation, sometimes use gabapentin to help with some of the mild withdrawal symptoms and cravings. So that could be initiated to help someone cut down a little bit. But if they're drinking that much that you're really worried that they're going to have severe withdrawal, then that's probably worth having a conversation with one of your colleagues who's more expert. And for a colonoscopy, yeah, maybe doing it in the hospital setting rather than in a clinic setting.
Thank you so much for that. So another thing that came up actually that you already answered directly, but I'll just restate it, is as to the use of semaglutide or these other medications there. And so, I saw in the chat there that you had indicated that really that's something that can be used for diabetes, for weight loss, but in the management of obesity specifically, but not something at this time that we would be recommending for a substance use disorder. Is that correct? Did I restate
Yeah,
that?
that's a great summary. Thank you.
Perfect. Thank you.
Yeah.
Thanks so much. And then another one actually that you had stated in the chat as well was why should doctors be recommending or okaying between 3 to 7 alcoholic drinks per week when we know only 0 drinks per week is safest? And so you had just mentioned that I think it's great to encourage people to have 0, but we all do lots of things that have risks. Very true. I try to approach it as helping people choose the level of risk that they're comfortable with. And there's a small increase in risk between 3 to 7 and a significant increase when we go past 7. I think that's really helpful messaging there. And then another question that's come up to answer live is with acamprosate. Someone's asking, I thought they needed to be off of alcohol for 3 days, but I've also heard otherwise. Can you please confirm if they can take acamprosate if someone's still consuming alcohol?
They can take acamprosate, and acamprosate, like naltrexone, does not make someone feel sick if they're drinking. So that's the first thing. Whenever we offer medications to people, I find the first reaction is it going to make me sick? I don't want that drug. And it doesn't, but acamprosate will typically work better in someone who has been not drinking for 2 to 3 days, because all of those neuroreceptors, NMDA, the sort of gabapentinoid type things that have been impacted by regular alcohol use get impacted by acamprosate. I think we don't know fully how it works, but I think that's sort of the high level explanation. And so it tends to work better in people who are still in that kind of missing something in those neurotransmitters kind of stage. And so it's good to start it then. I do want to say in RAM in the clinic, I'm seeing a lot more referrals from family doctors who've already started their patients on naltrexone. And I think that's great, because it means that people are really paying attention and thinking about starting something on their own. Sometimes it's working, and by the time people get to us, they're not drinking, and we can really reinforce and send back. Or if it's not, then at least we know what's already been tried and hasn't worked, and we can try to think around why. So it's really great to see that.
Amazing. That's definitely music to my ears as well. That's amazing to see. And I'd said this in the chat as well, but really, if you can prescribe an ACE inhibitor, you can prescribe naltrexone. It's really, as Dr. Wyman said, not complicated. We're very happy to help as well too, and guide our family medicine colleagues as well with this too. So really happy to see that. That's great to see. The other question, actually, I saw, Joan, you had answered this, but I think I'll just bring it up kind of as a bigger question too. So I saw a lot of messages in the chat about what you were saying, and that people were expressing, I guess, some challenges and I guess some guilt as well too, that if they kind of assign their inbox to someone while they're away and want to disconnect, that it creates that extra burden for, their colleague, and they feel like that's really hard. So, I work in a setting myself where actually we do that kind of cross coverage as well. But I'm curious from your perspective, if you have any advice for colleagues who might be in that scenario where they may want to be able to disconnect, but then it also means the others have to work more. So then how do you navigate that conversation?
Absolutely. I mean, I think the number one thing to name is like witnessing that this is a systemic issue, and it's a bit odd that this is how we were set up to work, and it needs to change on a systemic level as well. And while higher ups figure out how to do that, I think one way that we can do it is by shifting our perspective, our mindset, and what we're willing to take on and for and with each other. Always, if there's an option for even to have someone, perhaps just simply someone to cover someone's inbox, paying that collectively as a group for the week you're away, that may help lighten the load. Also, what if summer clinics are more lightly booked? I know that will have impact on income. Like, I know all of these have forces that you have to plan for, think through, budget for, but just the notion of, if we don't take breaks, and you don't have to take breaks in the summer, if you prefer to take a winter vacation, go ahead. And like, perhaps there's some in your office that want to do that versus others. The alternative is your brain stops working, you get burnt out, you leave medicine in your soul or in your body. And so when we think about how is it that we want to protect and fight for what we do love about family medicine, I just encourage that as a motivator to get creative, to think of barriers as not the end of a sentence, but as an ellipsis to then say, and so then what are we going to do about it? And know that it feels hard because the system does not support us and our society does not socialize us and encourage us to do that. And the way we can change it is by having conversations like this, where we do celebrate each other. So when you see a colleague going on vacation, say, good for you, how can I support you? And start to do that neutrally for each other. A little less perfectionism about how we manage things as well is always good in the mix. What can you mass archive? What can you just skim? I know it all feels chaotic, but honestly, if it's too much work, you have to start to get creative about how you divide up that work.
Absolutely. And I think that goes back a bit to some of the other talks we've had on like using AI scribes and other technologies, as you said, to just make those things easier, right? And give you back time. Because as you said, we need that time. We're human beings as well. And I think that was such a central part of your talk today. The other question I wanted to just highlight again is Dr. Wyman, you had just highlighted as well for the group that the dosing for the Sinclair method is 50 milligrams for the naltrexone. And on that subject of naltrexone, there was some questions, just if you could go over a little bit more about your approach for liver enzyme testing. At what point would someone be ineligible for naltrexone? Like, how many times the upper limit of normal do you use in your practice? And how often should we be monitoring liver enzymes?
Yeah, I use 5 times the upper limit of normal, so in the 150s. Although I will say I've had people started on naltrexone at higher doses. At higher enzyme levels. If their levels are higher, then I would repeat them at sort of 4 weeks and 8 weeks. I would monitor a little bit more closely. But most of the people that you'll be seeing will have ALT and AST in the 60s, 70s, 120s. It's perfectly fine to start naltrexone at that point. If they've had blood work done in the last few months before you're seeing them, you don't need to get blood work done again before starting it. Again, you don't want that to be a delay in getting going. It's fine to start and then do a follow-up. When else would we not do it? Yeah, if we have people with, sort of not compensated cirrhosis, that's not a good thing. And of course, we can't use naltrexone in people who are on opioids of any kind because it's an opioid receptor blocker. So if you have people who are taking, any kind of either as opioid agonist therapy or for chronic pain management, then they cannot take naltrexone, acamprosate, or some of the other sort of second-line medications like gabapentin, topiramate would be options. Someone asked about the cost. So LU and acamprosate are both covered on OGB with the LU codes. Acamprosate is quite expensive. It's a couple of $100s a month if you don't have coverage, and naltrexone is much less. So it's certainly under 100, but I'm not sure where it is in that sort of 80-ish kind of range, I think.
Right. Another question that came up is for university students, college students, that demographic tends to engage more in binge drinking. There's more of that culture around it, although I have heard a little bit of that changing these days. But any particular advice in terms of how we counsel those individuals? Because often they tend to be a bit, less understanding of what their personal risk is, wanting to fit in. So yeah, any tips or tricks that you found helpful in your practice?
Yeah, I mean, lots of us have to deal with that as parents, right? So, what is preing, right? It's going and pre-drinking before you go out. So having large amounts of alcohol, so you don't have to pay at the club or the bar. So I do think it's important. Whenever I was seeing a youth or adolescent asking about substance use, how they drink, how often they drink. They're sort of all by nature binge drinkers, right? They're not having a glass of wine when they come home Monday to Friday. It's 7 or 12 drinks often at a time on a night, or a lot more. So I just, talk about trying to slow down. Like, what's a reasonable amount for you where you're going to have fun but not feel out of control? I try to, get people to think about numbers. Is it 4, 5, or 7? Have any sort of negative things happened to them when they've been drinking too much? Also really talking about safety, like having someone who's your wingman, right? Making sure that there's always someone watching out for you and that you're always watching out for someone else, that you're, in charge of your own drink, because there are unfortunately still things that happen where people put things in drinks overall. Yeah, there's no magic to that, but I think it's having a conversation that accepts that people are drinking, that young people are drinking well before they're 19, and that there are things that we know that can increase their risks and ways to sort of try to mitigate that.
Thanks for that. One final question is around use of benzodiazepines. So when would you recommend that as family physicians, we should be using benzodiazepines for withdrawal versus alternatives like gabapentin? Do you have an approach in terms of the outpatient setting?
Yeah, in the outpatient setting, if you can use gabapentin, I think that's really ideal, because there are obviously fewer risks with gabapentin, especially if people start drinking again. I'm happy to share sort of an algorithm to treating withdrawal. The nice thing about gabapentin is you can actually start it in someone who's still drinking, use it to help reduce some of the subacute withdrawals as an anti-craving agent, and then worked with someone to setting their sort of abstinent state and ramp the doses up. So usually for withdrawal, it's anywhere between 300 and 600 milligrams TID, with up to an extra 600 at night. So people use quite high doses, like 3,200 milligrams of gabapentin for withdrawal. Benzodiazepines, though, are the medication of choice if someone has ever had a seizure disorder. And if someone knows that they've done well with benzodiazepines in the past, they're a really good option. But I typically require that there be someone else who can help to support and monitor that patient, a friend or a family member. People are actually doing this virtually also as a way of working around that. And usually it's diazepam because it's a long-acting metabolite. If you're doing it as an outpatient, you do fixed dose, not symptom triggered. So something like 10 milligrams 4 times a day is a maximum for day 1, then TID day 2, then BID day 3, then once a day, day 4 and 5. I sometimes see people coming who have these prescriptions for ongoing diazepam or lorazepam because it helps them to reduce their alcohol use. That's not a good plan, because what happens is people keep holding on to these prescriptions for small amounts. Of course, they help them feel better because they reduce their anxiety, but they end up having both a benzodiazepine and alcohol on board, and that's not great. So I prescribe them in a very time-limited way. I think my protocol works out to something like 22 5-milligram tablets, and then that's it. No renewals unless there's a conversation about what went wrong and why we're doing another planned withdrawal. I will say planning withdrawal helps so much for people who are working at meeting their targets and struggling. It really gives people a chance to kind of reset and not need to keep drinking to manage withdrawal. It's such a driver of ongoing drinking. And again, just kind of a plug for the Medify website and for RAM clinics. If you're not sure how to manage this on your own, there's clinicians who will help support you, support your patients, and then transfer back to you, and you can develop those skills along the way.
Fantastic, and definitely would endorse the Medify website. Super helpful resource. So thank you, both of you, for answering those questions. And we'll just bring up the slides just to show a few closing slides and end today's session. We'll just pull those up again. Perfect. Over to you, Eric.
Great. Thank you again. So just a reminder that besides this session, the OCFP also has another community practice session for mental health, addictions, and chronic pain in similar format. We also offer a Peer Connect mentorship program, which would offer one-on-one tailored support for those who would wish to speak to a colleague about management of mental health, addictions, and chronic pain issues. Next slide. So we do have recordings of this community practice sessions. This is a list of some past and popular sessions. They can be found and accessed at the URL listed on this slide. Of course, you can also do an internet search for COVID-19 community practice, DFCM Toronto, and you should find this as well. Next slide. This is just a screenshot of the website in which you can access some of these resources.
So with that, I'll wish you all a wonderful summer. I hope you all get some time to rest and rejuvenate, in keeping with Dr. Chan's wonderful closing remarks there as well. And that if you do choose to consume alcohol, that you do so safely and in keeping with the guidelines as well, and that you avoid contracting COVID and pertussis as well. So we brought it all together into our summer session today. So thank you all so much for attending and for all of your participation. Thank you again to all of our panelists for your great informative presentations. We will be having another community of practice on July 26th, so please save the date. And please don't forget to fill out your surveys to let us know how we did today. Thanks so much, everyone. Have a wonderful summer.